Time now for the Daily Answer, sponsored by Salem Surround on The Answer Now TV.
Cremu, he's the author of the Cremu Substack, and you can find him on X at Cremu.
Ask him how do you pronounce that, Cremu?
Cremu, welcome to the show.
Can you hear me now?
Yes, we do. We can hear you.
Okay.
You're a bit okay. There you are. You were a bit off center there. We'll get it right. But we wanted to have you on because you're a big expert on healthcare. Healthcare has totally taken over a lot of the discussion in the U.S. as one of the biggest sources of rising costs in America. You know, people are. Let's just play one of these clips. Actually, I think that'll set it up nicely.
Good primer.
How about we do? Let's just do 263.
Going to hear horrible stories. People are not going to be able to afford their insurance. I don't think even with subsidies they're going to be able to afford the premiums that are hiking up 100, 200, 300%.
Wasn't Obamacare supposed to fix that?
When people, not without the universal. I mean, there's
Affordable Care Act. Affordable was the first word.
And I want to throw up this as the last primer here, Cremu. 279. This is the average annual expenditures for health insurance per household consumer unit. And you can see that big jump there right when the Affordable Care Act was implemented into law. So healthcare is far outpacing the trend that we saw before the ACA was passed. So we call it the Unaffordable Care Act. And that really is the foundation for our discussion. So, Cremu, what is going wrong with American healthcare?
So I would qualify that last bit a little bit. I would say healthcare spending isn't really growing way over what you would expect before the ACA. We're looking at different metrics there, but if you use consistent ones, it looks pretty fine. The bigger issue is that we have it just shouldn't be growing this way in the first place. It is a completely broken system in the sense that we have created incentives that to make it worse. So, wow, sorry, it's really disorienting looking at myself twice on the screen here. Let me just get rid of myself. Sorry, I'm looking at myself and seeing this is there we go.
Don't worry about it. Don't worry about it. Just keep going. Okay. Just zone it out.
Yeah. So we have a lot of things in healthcare, post ACA especially, that are terrible in the sense that, for example, take the medical loss ratio requirement. This is the requirement that health insurers have to spend 80 to 90%, depending on the type of plan, so 85% of their premiums each year. So if they charge their customers X amount, they have to spend 85% of X. And the fact that they have to spend that amount is effectively a profit cap, so they have to make profits in other ways. And to make those profits, they look into other things like buying up the pharmacy benefit managers or buying up hospitals or sneakily changing the prices or even overpaying for drugs in order to meet the threshold of things they have to pay for. So you end up with costs just kind of running everywhere. You end up with incentives for vertical integration such that they're buying up everything else, and the number of competitors that comes into the market is very, very small. Because again, who's going to invest in a new company that has to spend 85% of its revenues every year? That's not a very good investment. But there's a lot of other issues. The ACA also, for example, had a lot of stuff that was informed by small, kind of crappy studies. So there was this idea that came about as an example of this, where hospitals run by doctors would be lower performing, and the reality was they actually didn't be higher performing. But the ACA, when it was written, this idea was not based on good empirical evidence. It was based on bad evidence. So they ended up banning doctors from establishing new physician-run hospitals.
Wow.
There's a lot of things in there that are just kind of very bad.
But Cremu, that seems like it should be illegal. How could you ban somebody from starting a business? I don't understand. Is this like a real ban, or you just can't get access to insurance funds or something?
No, it's a real ban. Unfortunately, you cannot start new ones. There are some existing physician-run hospitals that predate the ACA's ban going into effect, but you can't start new physician-run hospitals. And that's a specific thing. So if you want to give up being a practicing physician, you can still start a hospital, but you can't both be a practicing physician and run the hospital.
That's so interesting. So I guess just big picture, there's a lot of debate. You know, the GOP in Trump's first term tried to repeal and replace Obamacare. They failed, thanks to our late senator here. But I guess people talk a lot about rising costs, but if there were targeted reforms that the Republican Party could start advocating, what do you think some of the best ones would be?
Tons. So a lot of the problem is that we have good ideas that have been actually supposed to be put into effect. For example, price transparency is the law of the land right now. If you go to a hospital, they are required to provide you with a credible list of all the prices before any operation is done on you. You are supposed to be given a price that is reasonable and that you will end up paying, because once they, put the number out there, they have to charge that for you, unless some reasonable complication comes up. But the law is not enforced. The regulation for price transparency was supposed to go into effect on October 1st. And I looked around at a sample of local hospitals and I found, hey, you guys still aren't transparent about your prices. It's a lot of the issue with this stuff is that we don't actually enforce the rules, which is bizarre. I don't know. Like, what do you say about that at the end of the day?
That sounds like a good chance to do populism. Have the Trump admin just sue a big hospital, or like perp walk some random official at a really big hospital.
When was that law? When was that law passed into law? That was supposed to go into effect on October 1st.
So that was a regulation. The law that provided the regulation with power is very old. I think it's a decade old. If I recall correctly.
Did that get caught up in the government shutdown or something? I mean, or we're just
no, it predated it.
There's
October
just not
1st.
A mechanism to enforce it. The Trump administration should absolutely start ensuring this.
Yeah. Well, what else? Yeah. What else though? Yeah, we cut you off there a bit.
Well, there are tons of things. So, for example, patients are actually entitled to all of your data. If a doctor generates some data and goes in your EHR, you are supposed to be able to get access to that. You should be able to ask your physician and have your physician give that to you in some format that can be used by you, the patient. The same thing applies to the CMS's CLIA certified labs. So like IVF clinics, if a parent has some sequencing done in one of their embryos, they should be able to get that data. But they don't. In fact, I think it was September 14th, if I'm recalling the date correctly, RFK put out a little video saying that patients are entitled to their data, and at some date in the future, there'd be a little, not a hotline, but a little form online that you can go fill out to report when data is not provided to you when you ask for it, and they just don't do it. So it's not even things that are high cost that aren't being enforced. It's also things that are just good, from a patient rights perspective, that just nobody follows the rules, because there are enforcement mechanisms, to be clear. CMS can really start hitting hospitals very hard. They can hit providers in ways that make their pocketbooks scream, but they don't. And that is the big issue at the end of the day, is that they have enforcement mechanisms, they don't enforce them for all sorts of things. Another thing is, for example, site neutral payments. So if you are running a hospital chain and you buy up a clinic, you can charge hospital prices at that clinic location, even if they're totally separate. You just bought the location. You didn't change any way it's run. But that allows you to charge the hospital rates you're associated with the chain. That sort of thing should be outlawed. And it was supposed to be outlawed on October 1st. But guess what's still in effect? Non-neutral payments. It's absurd.
So, Kremu, it feels like you're sort of painting a picture that the health industry is plagued by death of a thousand cuts. There's maybe isn't one silver bullet, but we were
not
talking
just death of a thousand cuts. It's so big. It seems like they just feel that it's so big and so impenetrable they can just ignore.
They can just
rules.
ignore. But so we have to.
That's right.
There has to be an initiative, though, from probably the highest levels of our government to start enforcing some of these regulatory changes that are supposed to benefit the patients. So here's something we talked about in hour one, that a lot of the problems in the country you could sort of trace back to illegal migration, illegal immigrants. How much of the rise in healthcare prices could you trace back to illegal immigrants on the dole or within the system, or is that not a driver in your opinion?
Not a big driver. The most liberal estimate that I've seen that's credible is about 0.9%, and that's stretching it, honestly. I think it's not that much. The main cost drivers have to do with old people. Old people are the biggest parts here, and the fact that we have bad incentives for cost control, and we don't allow certain types of cost control to even be put into place. So the AMA is really your bigger problem here. Most of your growth is provider-side rents, and that means the payments that go to doctors that are way in excess of what the doctors, the care they're providing is worth. That's most of your issue. And we could lower provider-side rents by allowing more physicians. but we have placed an effective cap on the rate of growth, not on the actual number of slots, but on the rate of growth in Medicare funding for residency slots. So the number of doctors who can actually come in and compete with the doctors and lower the rents and make it so they're paid less, but they provide more because there are going to be more of them, is limited. It's been limited since 1994, and we just don't change the rule.
What happened in 94? What happened in 94?
Oh, this is amazing. So the AMA argued there was going to be a surplus of doctors. There were going to be too many doctors, and that this would cause a big problem. And you have to think, how can there be a surplus of doctors? Don't we always need more doctors? And the answer is, yeah, of course. But they managed to somehow convince Congress this was an issue that would impact the quality of care when it makes no sense. And then they got these limits set in place. And now they argue, to get away from the fact that they did this, they argue, well, we don't limit the actual number of residency slots, but they ignore that, yes, there's still limitations on the growth in the number of slots and the funding mechanisms available to create more slots outside of Medicare funding. So they created a broken system where we can't actually fix the issue with provider-side rents, which is roughly a third of all of the spending problem.
I think we should go through the break on this.
Well, no, we're going to go through the break. So, Kremu, it sounds like there's you said that these two buckets, they essentially lead to 90% of the problems with the ACA. If you were consulting President Trump, J.D. Vance, would you just say deal with this 85% ratio issue? And it sounds like one other, I forget what the other one is. No. Okay.
So these issues are unfortunately statutory. So statutory means that Congress is the reason for the issue. Congress has, in the case of the MLR, the medical loss ratio requirement that drives so much of the spending issues and so much of the lack of AI-related innovation in healthcare, the issue was given, Congress gave the HHS the opportunity to write up the rules. And they gave them some limits. And it said you have to write the rules a certain way, and these rules are terrible. But in order to reform it, you can't just have the HHS rewrite the rules because of those limits put in place by Congress. If you actually wanted to fix this issue, you would have to very likely, unless you can get some Democrats to agree, and I really doubt you could, you would very likely have to suspend the filibuster, which is something that Republicans should be doing right now, and then go and get Congress to change it. So were I to offer this advice to Trump, I would say, push on the filibuster, keep pushing. You have to get them to change the thing because you can't do it directly. But as president, you will be blamed for any sort of healthcare mishaps or just continuations of bad trends that we've had going on.
That is the big, tough question. We've talked about the filibuster a lot on this show, and because Trump wanted to get rid of it to end the shutdown. And we've generally said, end the shutdown, end the filibuster, but only if you have a home run slate of legislation to pass. Otherwise, you're just going to do some lame thing and then fart around, and then Democrats will have no filibuster to do their agenda, which is a lot more clear cut on what they want to do.
Scarier too, by the way. And so there are two, there's popular aspects of ACA, right? Is the uninsurable people, right? That you couldn't have some very expensive treatment that you need for the rest of your life. The
pre-existing condition thing. People like being on their parents' insurance.
And then being on your parents' insurance. Would your recommendation, just from a political standpoint, put your political hat on, would you say, let's keep those things in place and fix these underlying, I guess, statutory issues? I mean, you could instead of replacing Obamacare, you pitch it as like, hey, these reforms would make it better.
Yes, I absolutely would. So the big thing is, with respect to the pre-existing condition requirement, it does add a lot of costs. I mean, it obviously does, because you have suddenly people who are high cost being covered, and you're in the same pool as them, and you got to cover them. So that's a big issue. But if you fix the medical loss ratio requirement and you allow if you allow health insurers to make better use of their prior authorization departments, you can minimize the downside of those people because you can offer them more tailored care. You can offer them, you can say, hey, your doctor called for this, but we actually think there's a better option here. You can figure out what is more optimal to give them in terms of care and save a lot of that money that you would have wasted anyway. But you're forced to spend it. So it doesn't matter. At the moment, it becomes a bad thing in large part because there are no incentives to fix the issue from a technological perspective. Like, you can't go the technological route and minimize the issue the other way, which we totally could do if we fix this other issue. So I think keep that in place. It's fine because it's so popular. No one wants to touch it. And you really do still want these people to be covered somehow. Like, it's a humane issue. At the end of the day, you want them to be covered in some way. That isn't just like.
So one last question I'm thinking. Yeah. So you mentioned it's statutory issues on the biggest things, but what is the best thing you think the Trump administration could do right now, just with its regulatory executive branch authority? Doesn't need Congress, which is its own big problem. What could they do tomorrow if they wanted to?
They could fix tons of the issues with CMS. So like that site neutrality thing I mentioned before, it is totally able to be fixed. The issue is the enforcement there. They have that power to fix that issue and enforce it. And they've written up those rules, and they have changed those rules, and they have not enforced it. That is the big issue, is enforcement. And there are tons of things like this. So they could get away with fixing a lot by just enforcing the rules and change. There are some things they could change too. So they could be adventurous. There are some untested legal theories here, like Section 804 is the thing that allows you states to sign up to start importing drugs for their Medicare, Medicaid programs from Canada at Canadian prices. If they were to be a little adventurous with this, they could expand that by changing two parts of the regulation so that states could import Canadian generics that don't yet have a generic equivalent in the U.S., thus lowering prescription drug prices a lot. It's totally on the table to do a lot of little fixes that are in untested legal territory, if they want to try that, and they could meaningfully lower the cost of healthcare, considerably beyond what they've done so far with the negotiations. Because the negotiations, they've actually been getting kind of duped on. Like a lot of the Trump RX stuff that they've done, where they've tried to directly go to Pfizer and tell them, give us most favored nation rates. That stuff doesn't really work to cut prices very much.
For full shows, live and on demand, it's Salem News Channel. Stay informed anytime, anywhere with the Salem News Channel and 9:30 a.m. TheAnswer.com. This has been The Daily Answer, sponsored by Salem Surround on The Answer Now TV.